How do we do simultaneous implant placement and grafting? Which are the rules? In an intact socket, can you place an implant immediately? Yes or no? Yes? Can you do an immediate loading? Yes? In thin tissue biotype, connective tissue graft is the state of the art. That's what we learned in the last 2 days, right? Okay, when we have a buccal defect, coronally or apically, what do we do here? Can we do an immediate placement? Now I'm swimming against Dr. Lee's wave, right? Yes, we can. What do we do here? A grafting and a membrane or a connective tissue? What do we do over the grafting? A membrane? Yes? A connective tissue will be part of the graft, so it's not appropriate. A membrane and a flap. In thin tissue biotype, I wouldn't, and this is a plan which was published based on my experience and literature. We don't do an immediate loading. We close the site with an onlay graft or a membrane of the new generation. When you have more than 3 millimeter buccal defect, can you place that implant? Yes or no? Yes, if the implant doesn't exceed out of the contours of the bone. Then you use your sandwich technique described by Homely Wong, autogenous bone, bone substitute, membrane, and flap, and use a membrane or a method which reestablish your defect and your contour and your aesthetics. You saw so nicely sausage technique, titanium mesh, PTFE with titanium reinforced, and so on. And when you don't have interdental bone, what do you do? Oh, what do you do when you don't have interdental bone? Short implants, or also a vertical grafting until 4 millimeter with particulate material. We will see in a minute. Now, in intact socket, the right positioning of the implant is the key. Costa showed you how you place the implant inside the socket, right? But we can also load the implant, not only close. Okay? This is a case of an incisor extraction, immediate placement, connective tissue graft in an envelope technique. Emergence profile of a concave profile abutment, concave profile provisional abutment. And this is the final result. Or 2 implants, look at the thickness of the tissue. We don't have to do anything else. Nevertheless, immediate loading, grafting of the gap, and cover it with the membrane, which increases the soft tissue quality on the top of it. And look at the soft tissue quality after the concave provisional abutments. Group 2, horizontal or vertical, horizontal missing bone, 3 millimeters. This is we place a membrane inside the socket to reestablish the defect, but we don't raise the flap. We don't raise the flap necessarily. We don't do an immediate loading, close the flap, close the site. This is a concave profile of the running room, and this is the situation of the tooth after 7 years. You see the quality of the tissue instead of the recession, or in comparison with the recession of the neighborhood tooth. Group 3, horizontal or vertical defects which exceeded 3 millimeters. Now, you saw spectacular techniques with collagen membranes, with PTFE, with titanium reinforced. What works in my hand is the sonic weld technique, which is a polylactid membrane. And why I see the advantage there, I don't have to open the flap again. That is a resorbable membrane, which it will resorb between 6 months and 1.5 years. And I can reestablish this defect and transform this defect in a 3-bony wall defect with a condition that mesially and distally I have a bone peak. I look for bone, for vascularization, for origin of the vascularization, apply the polylactid membrane with an ultrasound technique, cover today with a collagen membrane with a property of increasing the soft tissue biotype, and close the flap. Advantage. I place the implant, but the defect has to be less than 3-4 millimeters horizontally and vertically. I don't have to open the flap again. And with this method, in the last 5 years, I have good results, no missing bone, no bone loss in the side, and that is also published in an article. Now, what about prosthetic management? Now we placed the implant in a right position, we grafted, and we took care of the soft tissue thickness, height, and quality. Look at the quality around implants with a concave profile of the running room. Now we know that the papilla between two implants or two teeth is depending of the tooth form and shape, proximal contact length, crestal bone height, and interproximal gingival thickness. So there are all factors which we can control. And you are for sure familiar with this article, which shows us that the maximum of the papilla is 3.5 millimeter between two implants. Nevertheless, today, we work with implant with platform switching design. What means that we have, instead of 1.5, the traditional 1.5 millimeter, only 0.6 millimeter bone loss. So we gained here 1 millimeter. We have more than before. We took care of the soft tissue to be thicker. And that means we have more supracrestal fibers, which are more coronally. And that can be maintained with that concave profile of the running room. And in 2009, where Dr. Lee was writing about the critical contour, that was for me mind-changing too. He wrote an article with a single tooth implant, and that, if we apply that in adjacent implant, by changing the concave profile in a slight convex one, mesially and distally, you gain 0.5 to 1 millimeter papilla between two adjacent implants. And in addition, if the triangle between the crowns is physiologically, then we gain again, and the papilla will fill out the triangle. So this is an old case of 7 years again. This is the recession and the natural tooth, and the implants have a stable soft tissue in between. Another old case with adjacent implants. Okay? The tooth is elongated, but the implants, soft tissue around it is okay. 4 implants adjacent. Now we use here a gumdrop, right? Okay. 6 implants. So what kind of restoration, how do we restore those adjacent implants? Cementing or screw retained? Screw retained. Now, nevertheless, I made for me the following rules, which makes for me sense. If I am far enough, if I have enough tissue thickness, that the margin of the crown is only 0.5 millimeter below the free gingival margin, and am far away from the bone, I can even cement with the vent technique or with a technique which is reducing the cement in the sulcus. In any other case, we will take screw retained when the soft tissue is thin. This would be also one criteria. And at least 1.5 millimeter from the bone should be concave. Okay? So let's go to applying those rules, which partly are from the literature, partly from my experience, and apply it to full arch reconstructions. Now, sometimes when the patient comes into the office, you treat the patient in a full arch. You have teeth to keep and teeth to extract. How do you decide which tooth or not which tooth, if you keep a tooth in the full arch construction or you extract it? So we have the rules of 5, 10, and 20. That means if after the literature and after your experience, the prognosis of the tooth is 20 years, you leave the tooth and you include it in the construction, not splint it, but you include it in the new construction of the patient. If the tooth lasts 10 years after the literature of your experience, Then you still leave the tooth, and after 10 years, you can, with a small procedure, remove the tooth, place an implant, and the full arch reconstruction can function continuously. Then you leave the tooth. But anything doesn't last 5 years after the literature or your experience, you extract. So that is how you treat the patient like a full arch. So like here, the front teeth will be extracted, the canine will be treated periodontally, and the way we talked in the last minute, and this is the final situation. Strategy 2 is strategy of full arch reconstructions, FP1 situation with a good aesthetic prognosis, immediate placement, immediate loading, without without opening the flap. The predictability is high, and then we can apply this rule of transforming the concave profile in a slight convex one in between the abutments, and you can see how the abutments are modeled, how the profile of the crowns is, where the contact points between the crowns are physiologically, and therefore the situation that you have in the model you will find also in the mouth. And after 6 years is no change, This is a young lady who needs a full arch reconstruction in the upper jaw. Now, we do a designing of her smile with a method which takes actually 5 minutes, and this is the basis for the wax-up, which is the basis for a digital planning afterwards. And following the digital workflow, we scan the models, we plan then the implants, the adjacent implants too, and here is the skill and the knowledge of the clinician very important in order to place the implant in the right position. Based on that planning, we have models, we get models and all the screw-retained parts and also the final parts which we need for the patient, the surgical guide, the provisional, upper and lower. And again, a guided surgery, also in aesthetic zone, is much more predictable than a free hand. Nevertheless, we have an error, a mean error of 0.74 at the entry point and 0.85 at the apex. So be careful in thin bone situations. It's, as I said, it's a guide, not a god. Now, this is the situation of the after extraction of the tooth and the perfect planning of the implant. And we know that having thick tissue biotype, having the distance to the buccal contour and the precision of the insertion, we will have a good result. These are the screw-retained abutments, provisional. That is how the patient goes home. And this is how she looks after 4 days. Now, this gentleman is also FP1. He's wearing a denture. Now, we do here also a scanning of the jaw and planning, a smile planning with bigger tooth that he has because there were two prosthesis teeth were too small. And this is the basis for a wax-up and of the planning. Everything goes as we know. Screw-retained abutments, provisional. That is how he goes home. Now, and this is how he looks two days later. After 4 months, we have a nice situation of the soft tissue, of the abutments. We do the impression and the zirconia frame with Emax ceramic work will be done. And this is the final result. He needs to clean too, right? But he's happy. Strategy 2 modified. What means that we have also a crown height space which doesn't need a pin component, but we have to open the flap in order to solve the horizontal and vertical defects. So in this case, we plan, again, on the base of the SMILE design and provisional in advance, and that will be finished for the moment of surgery, and the patient goes with fixed teeth home. This is a lady who needs to have all the upper teeth extracted. We did that time just an aesthetic guide, not a digital guide, and the provisional made in advance. The surgery will be done in an immediate placement procedure. The horizontal and vertical defects will be solved by sonic weld grafting of the defects, as we talked a few minutes ago, and collagen membrane will be placed on the top of the polylactid membrane which we used. This is the situation after the suture removal. We don't remove the abutments for the impression taking, and this is the final ceramics. Zirconia abutments with a margin 0.5 millimeter below the gingival margin, and this is the final result. Another patient, upper jaw should be restored through implants. The teeth are mobile and infected. In the lower jaw, we made a perio treatment and it's stable. And this is today, after 7 years. This is how the patient came. Is it against the religion, right? And this is how he looks now. Maybe it's not perfect, but it's plaque-free, it's infection-free in perio case. The strategy 3 of full arch reconstruction treatment is where we need a pin component in order to support the lip. But the procedure is more or less the same. So this is a lady who needs, she wants fixed teeth. This is what we offered her in the upper jaw. Procedure is the same, immediate placement, immediate loading, or also placement. Membrane, which thicken the tissue biotype. This is the aspect of the tissue. Because we need the tissue quality, not only for aesthetics, which is here not so important, the papillas, but we need it for the stability of the bone underneath. Impression taking, and when we need pin component, the first thing is an aesthetic try-in, and that will be the basis for a backward planning of the abutment that you choose and of the frame. So this is the work. She needs, can be screw retained or can be also cemented if the patient can clean, if the technician is constructing it appropriately. And this is after 6 years. Okay? Now, as I said, I afford to give my patient 20 years guarantee on my implants because I do that under the condition that the patients are coming every 4 months to recall, to hygiene, occlusion control, and decontamination. Why? Because we know that plaque will be formed in 3 months. So I do a control every 4 months. Once a year, we do an occlusion control with an T-scan, which is the most precise nowadays, as far as I know, and a decontamination. Why is it important? Why am I secure on that case or in doing this? Because I can see every 4 months a mucositis. A mucositis I can treat immediately, locally and generally, but a peri-implantitis not. So that's why it's a win. In a win-win procedure, I can give that long-term guarantee to the patient. Now, all these cases concluded showed me 0.5 millimeter bone loss in 90% of the cases using the implant design, position, tissue thickening, bone grafting in the manner that we talked before, high success rate of the stability, a high pink aesthetic score between 8 and 10, tissue thickness more than 1 in 90% of the cases, and the width of the attached gingiva more than 3 in 90%, almost 90% of the cases. So that is how I work in this stage, and I learned a lot these 2 days. and I will implement my way of working beginning with tomorrow. We need to do, as a conclusion, a sustainable bony situation in all these cases, and a sustainable peri-implant soft tissue. This is what we need to create also in full arch reconstruction. There is no perfection, but the preciser we are in the manufacturing, in our work, the more we are near to that perfection which we aim, and it's not reachable. And what we can do, all of us, is try to do out of our life, and especially of professional life, a work of art every day. Thank you very much for your attention.